This one is, as we talked about the other night, there's no way in the world we can get through anatomy in one night, perhaps even two. Yeah, you could sit here, I could sit here and read off all of the slides real quick, but that's not going to do you any good. Now that we're studying to be advanced level care providers, it's really important that we get into this a little bit better. Now, the other night I left off at the end of the end of the respiratory system, and we're fixing to get into the heart now, which to me is one of the most interesting parts of the body, or as a paramedic especially, because we can actually do stuff for that. So I put some extra pictures in here, so it made the slides show a little bit earlier. We'll go as like I said, I'll go as far as I can tonight in this comfortably without cramming too much. And we've got extra time if we need to move the days around a little bit, but we got to really cover this part quite adequately. So the heart, everybody knows about the heart, or do we think that we know about it? You can never learn too much about it. So it's about the size of your fist, right in the middle of it's not really in the middle of your chest. It sits more toward the left, the patient's left or your left, more so than it does in the middle, but takes up more of the left side of the mediastinum. And it is a big muscle. The circulatory system, exactly, it's one big system of a pump, plumbing, and fluid volume to go into that plumbing. So to have an intact circulatory system, you got to have an adequate pump, intact vascular system, and adequate amount of fluid. It really acts like, if any of you have ever worked offshore or on a production platform, it really looks like a big plumbing system with a radiator. So takes all three parts. When you have a problem with one part, the other parts will react harder as much as they can, compensate as much as they can, but eventually it'll give out when all of them's not working together. So it should be entirely enclosed to work properly. That means no openings, no cuts, no the heart was to give out, go into heart failure. It has to be completely intact for it to work right. And the systemic circulation, which is the vessels, vascular system in the body, and then you've got the pulmonary circulatory system, which is inside the lung. And they work together. One can't work without the other, but they are considered two different systems. One's a high pressure, one's kind of a low pressure. So next thing we're going to look at is this drawing here, this diagram. It's a little bit, I don't want to say complicated, but it's something you have to look at real close and just study on it, memorize the parts of it. Yeah, you're not going to, I'm not going to remember that enough to where I can write it down. However, as we see in this one, you got the heart that's attached to the lungs, and basically what that does is your body needs oxygen with the waste products that your body makes throughout the day, or throughout the minute actually. It turns into carbon dioxide, CO2, and it has to be gotten rid of. So it's a constant cycle. You're bringing in oxygen and you're getting rid of CO2. So it's constantly circulating and pumping, bringing in oxygen, giving it to the cells, and they make a trade. In order to get oxygen, they got to give off CO2, and then it's put into the veins, taken back to the lungs, and exhaled out. So this goes on continually all day long, all the days that you're alive. When you start having problems with it or it doesn't work anymore, then that's when you die. So it is as you can see, this is spread out. It's all compacted together inside the chest, very compact. And this kind of represents blood and everything throughout the whole body. Now we can see the aorta leaves the heart, goes to the upper body and the lower body, branching off different vessels, pathways on the way down. Then you've got the large vein, the inferior vena cava, which comes from below, and the superior vena cava, which drains the upper part, the head, and the upper extremities, and brings it in to the vascular system. So this is a compact scene of it that's normally be spread throughout the whole body. Now, the heart, it's a muscle. It is a muscle that's made up of very specialized cells called cardiac cells, and they have their own automaticity, which means that they're able to elicit an electrical charge of their own. They don't require charging from the outside. Now, it needs to be coordinated to work right, and we'll talk about the electrical conduction system when we get a little bit into it a little bit more. Let me see here, it's not working. I'm sorry, I got a slide up. It's not showing up on the thing here. I'm sorry. Y'all are still seeing the diagram, right?
Yes, I'm seeing the heart diagram.
All right. I'm not sure what. Okay, here we go. It was just a delay for me. There we go. Okay, like I said, the heart is the muscle center of the chest. It is a large muscle, specialized cells, and they're unique. Nowhere else in the body does this muscle type exist. Now, anytime you see the prefix myo, based on your terminology, myo means muscle, cardium, of course, means cardiac. So that muscle is called the myocardium. And these cells are kind of long, irregular, or long, elongated type shape, so they can have stretching and contracting type properties. So the blood, looking at the slide, it's really hard to pick up. So I put some pictures in coming up, but the blood enters from if you remember the right atrium, the right ventricle, which is on, if you're looking at it straight ahead, it's going to be the left side that you're looking at. So the right atrium, some books will call it an auricle. If you can see, the inferior and the superior vena cava, they drain the blood, they bring the blood from the body and from the head and the upper extremities into this right atrium. Now, just below that, you'll see a tricuspid valve, and that's because it's got 3 leaflets. You see some tendon-like, or those white-like structures that attach it to the bottom of the heart. That on the bottom of those little muscles and little extensions on the bottom, that's called papillary muscle. And the tendon-type white material that goes between those papillary muscles to the bottom of the tricuspid valve, that's called cardiac pulmonale or chordae tendineae, depending on which text you look at. But that is that's very tough. Almost, they say it's kind of like a strong fishing line. But what it's there for, it is when the atrium pumps the blood down, it allows the blood to go through. But when the ventricles contract, it doesn't want those valves to go back up into the atrium. So that's what those chordae tendineae are there for, is to keep the valves from going backwards. And it is a very, very tough fibrous tissue. The blood goes, after it goes into the right ventricle, that contraction, the blood goes through the pulmonary artery into the left and the right lungs. Now, that is the only artery that transports deoxygenated blood. Most arteries are vessels that transport blood away from the heart. Most of them are oxygenated blood because it comes from the left ventricle, which has already left the lung field. So what we're seeing here is the pulmonary artery transports blood away from the heart, but it is deoxygenated. It's full of carbon dioxide because that's what came in from the body. So it pumps it to the lungs to be oxygenated, as we saw in the previous slides, through the alveoli, gets rid of the CO2, it attracts O2, and it comes back into the heart through the pulmonary veins. Those veins, they transport blood to the heart. That is the only vein, however, that transports oxygenated blood because it's coming from the lungs to the heart. The rest of the veins in the body are transferring blood from the system itself, and it's got rid of the CO2, got rid of the oxygen and picked up CO2. So we got the blood coming back in through the pulmonary veins into the left atrium. The left atrium will allow the blood to flow down into the left ventricle, and when that contraction initiates, then that's when the blood goes out through the aortic valve, the ascending aorta, and into the head, the body, and the rest of the body through the capillaries, and it simply starts over again. Now, you got, when the ventricles pump, it's operating, you're pumping from the left ventricle into the lungs, I'm sorry, from the right ventricle into the lungs, from the left ventricle into the heart, the head and the body. It's constantly like that. So when you picture a contraction from the bottom part of the heart, when that's happening, the ventricles are open. The atrium are open. And that's when it's gathering blood from the body. When the ventricles contract, the atria are filling. So after the heart relaxes and opens back, that's when the atrium squeezes the blood down into the ventricles to be pumped again. So it's just constantly, you got 4 chambers working at one time. And when the bottom part pumps, the top part is relaxing, and vice versa. What happens is that there is some type of an atrial, what we call an atrial kick. I'm getting ahead of myself just a little bit, but I just want to explain to you when we got these this heart picture up here that you can see real good. But the atria, when they pump blood down, they do squeeze a little bit and have kind of what they call an atrial kick that flushes the blood out of the top part of the heart into the bottom part of the heart. Now that's when it's a regular rhythm and everything's functioning right. You may have seen a lot of commercials lately or heard of somebody that has AFib or atrial fibrillation. Now, what's going on there, and this ain't something you got to remember, it's just FYI, it goes along with this, help you understand it. But what happens there is those atrium up in the top, the right and left atrium, instead of pumping regularly in coordination with the bottom part of the heart, what they're doing, they're just simply, they're fibrillating. They're sitting there just kind of vibrating. There's no organized rhythm with them. That'll cause them to have an irregular heartbeat. But instead of the blood being kicked out of the atria like it normally should, that blood may tend to stagnate in there and not be pumped out all the way. And when that happens, it forms little clots. And those clots can get into the ventricle and be pumped to the brain, causing a stroke. That's when they say people that have atrial fib are more prone to strokes than people that are not, that doesn't have it. And that's why they lose the atrial kick, blood kind of stays back. It may clot a little and it gets pumped out and forms strokes or heart attacks. That's why they put them on blood thinners or anticoagulants, the way that works. Now, later on, I've seen it on a test question, is you're going to have to remember which valves are the atrial ventricle, the AV valves, atrial ventricle valves. Remember, in terminology, a lot of words are put together in order to help you to show where what they're talking about. You got the atria and you got the ventricle. So when they talk about atrial ventricle, it simply means the part in between the ventricles and the atria. And your atrial ventricle valves, your AV valves, are going to be your mitral valve and your tricuspid valve, because that divides the top part of the heart from the bottom part of the heart. So you'll see that one later, but that's important to remember, the AV valves. Now, the valves of the heart, they're not talked about a whole lot, but they are very important to this, because the I'm going to back up and show you the picture while I'm talking. But when you look at the this cutaway heart right here, let me back up just a step or two. And while we got it up, remember the myocardium is the heart muscle itself. The endocardium is the inside of the heart wall, and the epicardium is the outside of it. Now you remember from terminology, endo means within, myo is heart muscle, it means muscle, and epicardium means to surround. So that's the way those terms are broke down. Cardium means cardio, cardiac, And you got your endocardium, which means within. Myocardium is the heart muscle itself, and the epicardium is which is on around the outside. Now, you may have heard of endocarditis before, an infection which is located on the inside of the heart. Epicarditis may turn into what they call pericarditis, and the pericardium is a large sac that really contains the heart, that's around it, that contains it. It's kind of like the pleura surround the lung, but so you got the pericardium that surrounds the heart that provides lubrication for it, so it can beat inside of it without friction, and it can also become inflamed or infected. You've heard of pericarditis maybe, or even if you have vessels on the outside of the heart that may rupture, that fill that pericardial sac, that cause the heart to not be able to pump as good. That's we'll talk about cardiac tamponade later and trauma and things like that. But that's kind of where that all takes place at. Now, when we talk about next to the organ, like the pericardium, remember visceral's next to the organ, parietal is on the outside. So even the pericardium has two layers, and on the inside you'll have the visceral pericardium, on the outside parietal pericardium. Now, let me go on to the valves again, and I just talked about most of the valves here, the way that works. But these valves are called clusps. They're like flaps. They almost look like dog ears in a way, and they simply keep the blood from backflowing. Now, we may have heard people that have a murmur, or maybe you have one yourself, or you've known someone that's had one. And what's happening there is you can see where that blood's supposed to be going in one direction, but when that heart contracts, that valve may not close correctly like it's supposed to, but it will backflow through that valve backwards from where it should have came from. And that can cause people, if the blood's not getting to where it should be going, that could cause them to have some like shortness of breath or lightheadedness or problems with blood pressure. Everybody, not everybody, but a lot of people have murmurs and they don't even know it. And that's because after time, as you get older, these things are going to wear out a little bit, and that's just a normal part of aging. However, sometimes it does get bad enough to where they may have to do surgical intervention or put somebody on top of a beta blocker type pill that causes the heart to not be so stressed. Now, we can see where it's called the aortic valve on there, and you see where that blood goes through there. It goes under the pulmonary artery, but out through the top of the aorta to the body. Now, that blood will pump through, when the ventricles contract, that blood will pump through the aortic valve, and also on the right, on the opposite side, the pulmonary valve. So when that blood pumps through there, as soon as the heart quits contracting, it's going to flow backwards unless those valves work right. That's what those valves are there for, is to keep it from flowing backwards. That can cause issues, especially with older people. Now, there again, this is something that, when I tell you some things that, like I said, you really wouldn't really be required to know. However, if you do know just a little bit expanded stuff, it kind of helps you understand what's happening a lot. Now, so don't get discouraged if I say something that we hadn't covered yet. We'll get to it. But sometimes, like with elderly people, I know my mother-in-law was just one of them that this happened to. She would get short of breath with exertion, and when I take her blood pressure, the systolic number would be a little bit elevated, maybe 140, 150, but the diastolic would be like 50 or 60. Now, why would they be that much of a spread? The systolic is the measurement of the artery contracting, the pressure against the blood vessel. So when it contracts, that's the systolic. And diastolic is what you get when the heart relaxes. That's the non-pressurized blood pressure inside the system. So what's happening there is a lot of time the aortic valve will be bad, and that blood will get through the pressure that it's supposed to get. But when that valve doesn't close, it will come backwards through it. And that's why they'll start getting short of breath. They can't really make exertion. They'll start breathing real hard. A lot of times they're okay when they lay flat, but when they sit up, they'll start getting real tachypneic, start breathing hard and fighting for air. And if you got those real widened blood pressures like that, that may be what's going on. But she's had to have 2 of those valves replaced. But anyway, it's just a little interesting tit for tat for that I think it's pretty good to go on to talk about. The next is the blood flow from the heart. I went over that okay verbally, but it's better if you just see it right away, just to kind of a recap. Like I said, you can never cover this enough. But, it's fascinating. This happens your heart beats every couple of seconds, for as long as you live, all the time. So it's amazing how this keeps working. Now, as you can see, the left ventricle has to pump the blood the further, so it's usually quite a bit thicker. It's more muscular, and it has to pump harder. That's one reason it's a little bit thicker than the right ventricle. So, but sometimes those heart muscles can get inflamed, or if they've been overworked through a long period of hypertension or anything like that, they may even get too thick, what they call cardiomyopathy, where they'll get even thicker, to where now that they're thicker, that makes the ventricle less have a less volume, so they can't get enough blood in, so it'll start beating faster to make up for the loss of blood volume, and it'll start working harder and harder. And that's when they start having heart failure, cardiomyopathy, things of that nature. So that's kind of where it starts at. Now, it talks about heart sounds here. I really didn't have to worry about describing heart sounds until later on, and it takes really practice to be able to determine these. But the first one is called a S1 lub. The second one is a S2 dub. So, and what this is the closure of the S1 is closure of the mitral valve and tricuspid valves. Remember those AV valves that we talked about? And the second one is the closure of the aortic and pulmonic valves at the end of systole. Hold on, my PowerPoint's giving me problems again. Give me just a second. What we do without modern technology, y'all. Okay, here we go. Okay. One way where you pretty much get your practice with this is a lot of time with interfacility transfers or something where you have time to really do that. Now, a lot of time with acute emergencies, people are anxious, might be a heated scene. If you got time to look, to listen to that, that's fine. Make note of it. And but on our facility transfers, a lot of time where you can listen to this and kind of get an idea of how these actually sound. Now, if someone actually has a murmur, which was like the blood going backwards through one of those valves, it may sound like a whooshing like noise, like it'll like whoosh, whoosh. You'll be able to hear that. And if you hear it without ever hearing it before knowing what it is, you may or may not pick up on what's going on with it. But I learned a lot of my breath sounds and cardiac sounds when I do interfacility transfers. I would look at the past medical history, and I would see on there sometimes where, hey, this person has aortic stenosis or mitral valve stenosis, and I would listen to it, and you'll hear that. Sometimes a tick, sometimes that swooshing sound, and then you'll remember it from then on. And then when you do hear it on a first-time patient or something like that, you'll be able to say, oh, give you an idea what's going on. But and that could play into, it can cause chest pain, it can cause shortness of breath, it can cause fatigue, it can cause people to have syncope. And so those are just some things to note for your history gathering, and maybe some stuff that you can relay on to the physician. So now we're starting getting into some stuff now that I actually think is kind of exciting. Electrical conduction system. I'd mentioned earlier that electricity controls a lot of functions inside your body. That's how you're able to get an EKG or an EEG from the brain. So the brain partially controls the heart. I mean, it is sometimes controlled as far as rate, strength of contractions, and that's called the autonomic system. It happens without you thinking about it or exercising any control or willpower to make it work. It's usually going to beat on its own. So, however, if those cells in the heart can also generate their own heart rhythm itself if it needs to. And I'm going to show you some slides in a minute to help you kind of see that a little bit better. This is not a whole lot that you're going to have to remember, but what happens with the cardiac system is when you look at it this way, you see what in that right atrium, which to you is going to be on the left, but you see what's called the sinoatrial node. That's the SA pacemaker. It's called the SA node. And we all have one. That's your normal pacemaker. That's your natural pacemaker that you have already in your body. And it usually initiates an impulse from about 70 or 60 to 100 times a minute. And that impulse will actually send a signal down to what they call the AV node, the atrial ventricular node. It travels down the bundle of His, which it splits right in the middle of the septum, right in the middle of the heart, and then it goes to each ventricle and it initiates a contraction. So, and those are called right and left bundle branches. So, when your natural pacemaker will fire, it will send that signal to the AV node, and your ventricles will contract. And while your ventricles are contracting, the atria are relaxing, and then when your atria contract, then your ventricles are relaxed so they can gather in the blood. So the SA node is around 60 to 100 times a minute. The AV node will trigger a beat. It has an innate rate of about 40 to 60. And when you start getting down into the bundle branches and the Purkinje fibers, you're talking maybe 20 to 40 beats, which is really not sustaining for life or to be that part down. So these impulses are supposed to connect to the top part to the bottom of the heart. And you simply get the top part will pump, like we said, into the bottom. The top part will relax, the bottom part will pump. And it's supposed to contribute like that. That's the way it's supposed to work. The SA node sometimes goes out or doesn't fire right. That's when you have the atrial fibrillation. When the bottom part of the heart, when the electrical system is off down there, it can start beating so fast to try to catch up that it'll have either ventricular tachycardia or worse, VFib. And what you do at that point, you got to shock the heart and let it reset, or hope it resets. A lot of times it does, sometimes it don't. So that's what defibrillation is. And again, we'll get into that more later on. But at this point, this is just the anatomy and physiology. This is just going to scratch the surface right now. So what does this look like? I put this in here just to give you an idea of the way this kind of works. An EKG is simply, it just captures what the heart did. And we're not going to break all this down a whole lot. I just want to show you the P wave. That's the SA node firing. And where it says QRS, where it goes down and back up and then back up again, that's the QRS. That's when the ventricles fire. That's when the ventricles are firing, the atria reset, the ventricles fire, And you see that where it calls a T wave, that's when the ventricles recharge. That's when they reset, and then it does it again. This is the way it's supposed to work. P wave fires, the ventricles pump into the atria pump into the ventricles. The ventricles fire through the QRS. They pump the blood out, and then they reset in a T wave, and they do it again to the next one. So that's when that's simply the way the EKG captures it. This is there's other things that we look at later on. If you go on to be a paramedic or RN or something like that, you start looking at some other factors on here. But as far as what we're covering tonight, the picture you saw just before that, that's what you're looking at. The SA node firing and the ventricles firing. That's what it looks like on an EKG. So now, regulation of the heart function, you got to worry about the rate, how fast it beats. Chronotropic means simply, you think chronological, how fast. That's the rate. Dramatropic means the rate of conduction. And inotropic is the force of contractions. Now, for the most part, these are controlled by the brain through the autonomic nervous system. In other words, you don't have to think about it for it to happen like this. On the heart, you've got when the brain in the autonomic nervous system, you have what they call baroreceptors in the aortic arch and in the carotid arteries. When the baro means pressure, when your blood pressure goes down or it feels like it's not getting enough pressure, your heart's going to receive that signal. Said, hey, we're losing pressure here for some reason or another. And the heart's like, well, we got to make up for it. Let's beat harder and faster. So that point, the heart will be, it releases catecholamines into the blood and everything, and it causes the heart to beat harder and faster. Well, let's say that the heart will release adrenaline or epinephrine, and what that does, it causes vasoconstriction. So if you squeeze the system, pressure will go up. And also, that's what you call alpha effects. Alpha means vasoconstriction, because epinephrine has 3 different properties. It has alpha properties, which are strictly vasoconstriction. You have beta properties. You got beta 1 and beta 2. Beta 1 simply means the control of the heart. It simply controls the heart. It doesn't do anything with the blood vessels. Blood vessels are alpha. So it says, hey, we're going to increase the force of contractions. We're going to increase the rate of conduction, and we're going to increase the rate. That has to do with inotropic, dramatropic, and chronotropic. So it does all of that at one time with epinephrine. Now, think about when the heart is stopped. What needs to happen? We need to make it beat. Well, how do we make it beat? They give epinephrine IV, which simulates this. It makes the vessels contract, and it's supposed to try to make the heart contract and beat. Doesn't always happen. Sometimes it does. So that's why epinephrine is made. It's for the vasoconstriction and to make the heart to try to beat harder, faster, and stronger. That's the reason for it. If your body can't do it naturally, then we try to give it artificially to try to get it started. So at any time anybody wants to key in, if you get me to clear up something, I will. And this will make more sense as time goes on. Expect to become confused and frustrated during this class, especially when you start getting into the ALS stuff. That means it's supposed to happen that way, and then it'll kick in. One day it'll click, and you're like, oh no, okay, now I got it. But expect to be discouraged and kind of I don't want to say, just expect it to get hard, and difficult or challenging. That's the word I was looking for. Expect it to get challenging, but don't get discouraged from that. So, but the cardiac cycle, that's that process we described that's what creates a cardiac cycle. It starts with a contraction of the atrium, contraction of the ventricles, and it simply starts all over again. Now, systole, as I talked about earlier, that's contraction of the ventricles. That's the top number when you take a blood pressure. That's the pumping of the blood into the systemic circulation. Systole means contract. So that's the top number you get with the blood pressure. But you should have, you can't lose complete pressure. So even when the heart is not contracting, in between beats, that's when you hear that's the bottom number, or diastole as they call it. But you still should have some back pressure in there in order to keep it from losing the prime or anything like that. When you lose diastole, it's probably because of the valve problems. That's kind of like control valves or check valves that kick in and keep blood from backing up. But when the diastolic drops way down, you may have some type of a pump failure when that does happen. So something that we call a pulse pressure or a MAP, mean arterial pressure, and we'll talk about that later on. But we'll get into trauma and stuff, but right now, don't let that get to you. But pulse pressure is called MAP, and that's the difference between the systolic pressure and the diastolic pressure. That's in some cases, you might not be able to get like a blood pressure like somebody that has an LVAD or a ventricular assist device that we'll cover later in cardiology. But sometimes all you'll be able to get is that pulse pressure because their blood is constantly churning on one of those artificial ventricular assist devices, and that'll come in more into play to that. Also, the pulse pressure, you may have erratic diastolics and systolics sometime, and a MAP is something, or pulse pressure is something they'll use to be able to determine if they're actually getting organ perfusion. This is just a picture of what systole and the diastole looks like. Like I said, the ventricles squeeze, the atria are open. Then when the ventricles relax, the top part of the heart is squeezing blood down into the bottom. And as you can see, during diastole, you look at those aortic valves and those pulmonary valves, they're shut when it's filling up because that blood is already pumped out. It does not want to let it backflow into the heart and make it lose pressure to the brain or the lungs or wherever else. So during diastole, not the AV valves. During diastole, the AV valves are open, but the pulmonary and the aortic valves close tight to keep the backflow from happening. These is one that I threw in there for the simple reason of when does the heart get its blood? Now, if you look here, if you look on the left in that systole, that blood is pumping so fast and so hard, it goes out. It has to go out enough to eject it through the pulmonary, through the aortic arch up into the head. So if there's anything right on the other side of that aortic valve, it's going to bypass it, right? Because it's going by so fast. So when does the heart get its blood? Now, if you look over on the right, again, the diastole, you see that how the aortic valve is shut right above that aortic valve. You'll see these two arteries coming off outside the heart. That is your coronary arteries. So when that valve shuts, when the blood backflows against it, that's when your heart muscle receives its blood. So that's one reason that somebody that has a bad aortic valve, if that blood wants to bypass it and not stop, that's one reason they start having chest pain, shortness of breath, weakness, because the blood's not getting into the coronary arteries. It's falling back past it, going back into the heart. So that's why it's important that aortic valve shuts. So you can see here the left coronary artery and the right coronary arteries. The left coronary artery feeds the left ventricle, which is the part that pumps blood to the rest of your body. And if you get right where that arrow points, about midway, that left coronary artery points right there into the circumflex. If one of those are occluded, that's what they call the widowmaker, because if that's occluded and it starves that side of the heart, you're going to die unless they get it open back up. The right coronary artery and stuff, you can get your pressure and stuff will drop like that with that part, but it's not as deadly as the one on the left. So those, I just put this up here to kind of show you where those are, where how your heart gets the blood. It comes off that aortic branch and flows into there under low pressure. So that is the way that part will, the way the heart gets its blood. The couple of terms here. Afterload is the pressure that the heart has to pump against. For example, if somebody has high blood pressure or some types of constriction for that matter, then it's going to be hard for the heart to pump, and you're going to get, it's going to cause the left ventricle to become overworked. So afterload, remember, is the pressure that the heart must pump against. Cardiac output is simply the amount of blood that the heart pumps in 1 minute. And you're really not going to know the stroke volume in the field. You're just really not. They have to measure that inside a hospital with some central lines and things like that, excuse me. So, but the stroke volume is the amount of blood that pulls out. The cardiac output is how much blood is pumped through the circulatory system in 1 minute. Now, when I showed you that area of the heart right here earlier, when someone's having a heart attack, and let's say that the right side of the heart, remember the right side of the heart has the right atrium and the right ventricle, and that collects blood from the rest of the body in order to be able to pump back to the lungs. Well, that right heart has to be able to pump that blood from the circulatory system into the pulmonary system. But if that right coronary artery is occluded and they have what they call a right-sided heart attack, a lot of times their blood pressure will drop real low because that right side of the heart is weak. So you see where it talked about, excuse me, my PowerPoint's messing up again. So that right side of the heart can lose fluid that it's pulling in. That's one reason when you see this next slide where it talks about Starling's law, is that's where the heart muscle itself can be stretched. That's where, like later on when we talk about fluid resuscitation, and if someone has a low blood pressure, what you're going to be doing is when you give a fluid bolus is you're trying to stretch the ventricle. And what does that do? If you stretch it, it's going to cause it to pump harder and hopefully get the blood pressure up. So what you're doing in effect is trying to initiate Starling's law of the heart, and you'll get a patient low blood pressure. Okay, well, we need to give a fluid bolus. Why are we giving a fluid bolus? We're trying to stretch the inside of the heart to where it will make it contract harder and hopefully get the blood pressure back up. Now, another term is preload, and preload is what the pressure is or how much blood is available to the heart. So if you have someone that's bleeding out or the right side of their heart is not pumping right, they're going to have a low preload. That's what's available for the heart to feel. That's what's available to come into it. So what happens if they have a low preload? Let's give them a load. We're going to give them a bolus of saline and try to get their heart rate up like that. So that's simply what Starling's law is talking about. Now, The this is kind of a review, but it gets it down on a microscopic level because of the arteries take the blood away from the heart, and when it's leaving the heart and the lungs, it's going to have oxygenated blood. So when you see how the capillaries are usually only about one blood cell thick, so they're very, very small, and it has to be that way in order for the blood to be able to transpire those gases. When you start getting the fluid or edema or things like that that inhibit that blood flow, that's when you're going to start having some problems. But as you can see, the O2 comes out of the blood cell into the nutrients. And as soon as it gets rid of the O2, it's going to pick up CO2 and waste. It's going to transport it through the capillary into the alveoli. And as you see that big capillary right there, that capillaries are actually left, but are small. But you can see where the CO2 goes out, O2 comes in. They have to trade places. They don't like being in the same place at the same time. So, but the arteries get even smaller and smaller. You got your large arteries, then they branch off into smaller ones, and they actually get into arterioles, which means microscopic capillaries. It'd be very difficult to see these without an unaided means with a microscope or something like that. Now, the vessels, arteries have muscles in them, smooth muscle that actually help cause the constriction to make it go up. So the outside of the artery, you got three different layers. You got the adventitia, which is the outside. The media is in the middle, intima is on the inside. Now, some of your big arteries, like your aorta, has this as well. But you may have heard of, let's say, the endothelium breaks on like your abdominal aorta. The elastic tissue starts to break. That's when you start like getting an aneurysm or a dissection, and it starts actually tearing out of that. One reason that you heard of blood shunting before, like if you're cold, it shunts away from your skin. It's those arteries on the skin, those smooth muscles contract and push blood away from that. Capillaries are in between the arteries and the veins. They are very small. They're very delicate. They don't have muscle. Blood has to be pushed through there by the arteries, and they can't take a whole lot of pressure. They may, like if someone gets septic or acidotic and their hydrogen ions go up, those can actually be broken down. You've got capillaries inside your kidneys, and people that have high blood pressure that causes those to rupture, can have kidney failure, or even someone that has diabetic ketoacidosis. Their blood becomes like acid. It'll actually deteriorate those. Now, if you look down at the veins at the bottom, they do have some the outside connective tissue. They do have some smooth muscle properties, but it's not near as pronounced as what's inside the arteries. And they also have valves, one-way valves that try to protect blood flow. Since they're not under high pressure, blood may tend to backflow, so that's why they have the valves in there as well. So it's a very unique but delicate system. The circulation to the heart is I showed you a picture of this already, but it has to do with the coronary arteries, and it actually branches off 9 different times. So there's actually 9 different areas of the heart that they can stent. Some's more difficult than others. It's kind of beyond the scope of this class, but by looking at when they do 12 lead EKGs, it'll show you what area of the heart that is occluded. And that's why if you go on the paramedic school and things like that, then you'll be able to, get deeper into that. I just don't want to overburden anybody with that right now. Some of the stuff I tell you is just FYI. So I'm not sure what's up with my PowerPoint, y'all, but it keeps bugging out on me, and I do apologize. And this is a part that was in the original slides that I've kind of, I put another one in there. I thought it was better for you to look at. But just another picture of the coronary arteries, how delicate they are. They're some of them on the outside. You know, how wide are they? In an adult male, probably of average or above average size, those arteries, coronary arteries, especially the big ones where it says circumflex and the left main artery, they're going to be about the size. If you think of a piece of elbow macaroni or, you know, like mac and cheese, probably about that size is what they're turning out to be. The just another picture of the kind of enclosed and not divided up like we'd seen earlier. But you can see the heart does have some fat around it, and that's, you know, insulation. It's kind to keep the vessels and stuff in place. And I don't know if any of you have ever, like if you're a hunter or anything like that, you cleaned a deer or an animal and you can see the heart, you won't see a lot of fat around those arteries like a deer or things like that. However, what you will see is sometimes some white fibrous tissue around where the arteries are. And that's kind of what that is. Now, the heart muscle is actually made of cholesterol, and it actually has a lot of cholesterol in it. So if you ever were to like cook or think just the heart itself, it will get a lot of fat off of it. And it's kind of gristly and greasy type. But you can see where those, as far as when you look at a diagram of the heart that's dissected, like we looked at earlier, the ventricles actually look like two round areas that are real defined. When in fact, not the ventricles, the atrium. When in fact, if you look at this, the atrium are actually look like little flat hound dog ears or something like that on the outside. They don't look like they do in the regular drawings. They just look like two pouches out there that are kind of floppy and doesn't appear to be well organized. So don't let that fool you if you look at something like that from the outside. This heart really doesn't really look like a whole lot the ones we'd seen cut in half earlier. But you can see the arteries and veins that feed the heart muscle. Anterior is the front view, and the posterior is the back. Now you see that big left ventricle from looking at it from the back. You see how big that artery is and stuff across the back. So that's why sometimes people say, well, they're having back pain from an MI because that's some big area on the back side of it. And that, again, is part of the Widowmaker cardiac issues. I promise you we'll get through this tonight. I apologize again for it. Any comments, questions, or concerns right now about anything? I'm not moving too fast, or I don't want to have anybody confused or anything like that. Is it making sense to anybody? Okay. All right. Thanks. I sound like I know I sound like a nerd with this stuff right here, but I find it real fascinating, and I can go on about the heart part forever. That's why I love teaching ACLS and things of that sort. Okay. 100. I'm going to work on this tomorrow and try to get it fixed. Anyway, pulmonary circulation, these are just some terms that you may see later. We've already been over it, but just to break it down in some terms, but pulmonary circulation, it carries blood within the body from the right side of the heart to the lungs and back to the left side. So it stays between the heart and the lungs. It the pulmonary circulation is a tight knit area. It doesn't go outside the heart, but remember, it's between the heart and the lungs. It's kind of like their secret. That's what happens there. The pulmonary circulation, you can have its own hypertension. You've heard of pulmonary hypertension or uh, pulmonary issues such as that. And that's pretty much where that stays at. Say like pulmonary embolism. The heart may discharge a clot that goes to the lungs, and sometimes it don't come out of there. It stays in there. And when we get into medical emergencies, respiratory issues later, we'll get into that a little bit more in depth. So we're just scratching the surface on that right now. But remember, the pulmonary circulation stays in between the lungs and the heart, and it's got the oxygenated blood from the right ventricle that goes through the pulmonary valve into the pulmonary artery. So that's the only artery that transports any deoxygenated blood. All right, the systemic circulation, which we've already been over, but we're going to look at some terms because terms tend to turn up later when you need to recall them. It's when the oxygenated blood leaves the heart, and I know I'm reading the slides, I don't like to do that, but I just want to make sure you get the terms down. Oxygenated blood leaves the heart through the aortic valve and passes into the aorta, and it starts to break off. There's three major arteries that rise from the aortic arch. And the aortic arch, I'll try to get some x-rays or some pictures of that to kind of give you an idea of what we're talking about. But there's three of them that come off of it. Now, if you think about your terminology, Brachiocephalic artery. What's that? Brachial, you think of your arms, brachial areas in that way, and you think cephalic, which is head. So that's the one that branches off first and goes to your arms and to your head. Then you got your left common carotid artery and your left subclavian artery. Now, it seems like it's taking care of the left side quicker than the right side. But what's happening on the right side is where that brachiocephalic artery goes to the right, it's actually breaking off of that part. So then the aorta divides into the descending aorta, which is the part that it loops on around as far as the arch and goes down into the thoracic aorta and abdominal aorta, and it branches off of it. And we'll see some diagrams of it here in just a minute. Now, as you can see what we talked about at the top, you see that the big red part above the heart, that's the aortic arch. And you see where those arteries break off from it. They go to the head, they go to the upper extremities, and then it goes on down, branches off to the kidneys, and then it bifurcates again, going to each leg. Now, where it breaks off in the abdomen, the abdominal aorta, when it breaks off into the abdomen, when it's inside the pelvis, it's called iliac arteries. When it goes through the groin and down the leg, that's when it becomes your femoral arteries. Now, you see the veins are written in blue or painted. They've always painted in blue because that just emphasizes, help you to tell them apart, and I guess by indicating that it's deoxygenated blood, but it's mainly just to help you tell them apart. So if you look at like those large veins right there, and you might see the one that's called the saphenous vein. That's the largest vein, longest vein in your body, the saphenous vein. You'll remember that. And you could other than that, you don't have a lot of big veins in your legs. So the ones that you do have sometimes tend to get overloaded, and that's why like a lot of the DVTs, deep vein thrombosis, or anything like that, kind of get lodged in there. Look at the circulation around the knee. You got a lot of circulation that's going in there. Your popliteal arteries, your anterior tibial arteries, and your aorta going down your leg is probably, for the most part, or those large arteries going down your leg is probably the size of your thumb. So you think about I'm sorry, my boss texted me something. I got to text him back right quick. But it takes about a minute and a half, really, 2 minutes, that somebody can actually bleed out from these arteries. Also, the higher up you go, the bigger those get and the quicker the volume comes out. Now, once the arteries enter the legs like that, you can see where we could pretty much try to control some of that bleeding. Tourniquets, direct pressure, but your internal large arteries inside the abdominal cavity, chest cavity, there's really no way to control that from the outside. How do we control that? That's when they got to be rapidly transported to a trauma center, because there's nothing that heals like cold steel when it gets to that point. You look at how big the arteries are that feed the kidneys, and look where the kidneys are. They're about even with your elbow if you put your arms down by your side. Look at those large veins on the arms over there. That's a lot of the ones that you're going to be going for your IVs. Now, a lot of hospitals, things like that, I see where they start IVs in the hands. I don't like doing that. Like I said, we're getting ahead of ourselves a little bit. We're not to that point yet. But as you can see where those are, the major veins are in the arms. The antecubital, which is a big one people like to get. That's great for severe trauma, life-threatening emergencies. But stop and think about it. If you ever had one in that fold right there, if they're not in a life-threatening emergency, I wouldn't go straight to there. I'd try down in the forearm someplace to where it doesn't cause a lot of bending or a lot of distraction like that. And that's, like I said, that's for later on. But this just kind of shows you a quick overview of those large vessels inside the body. A lot of time where aneurysms occur is that large thoracic or in the iliac arteries. That's where the aneurysm it swells up and it bursts even. A lot of times, because it's still pretty close, but I had a patient that severe abdominal pain radiating into the back, and when I called it in, we were coming in hot, and I had 2 large bore IVs in place, and still couldn't get the pressure up. And the physician said, "Hey, is he hurting on the left or the right?" And I said, "Sir, put your hand on it." He put his hand over the left side, and I mean, if you see where the aorta is, it does. The left short aorta is a little bit on the left side compared to the vena cava. Not always, because I have had people have aneurysms that ruptured that hurt all over their abdomen. They couldn't really pinpoint it. A little bit of regional anatomy here as far as in the neck. Now you see where the Brachiocephalic Artery goes up into the head, and it forms it goes all the way into the brain, and it feeds some structures on the way up. Now, you'll see an area there where it's called the Carotid Sinus. That actually has some extra musculature in there, in that vessel. And for the reason being, is if you ever stand up real fast, and you stand up sometimes real fast, and you feel that extra contraction of a heartbeat or something in your neck. And that's because your body, remember we talked about those baroreceptors inside the aortic arch, and when it feels that pressure go down, it automatically starts squeezing the heart harder and a little faster to increase blood flow. Well, that carotid sinus actually increases it just a little bit more when it can. So that does a couple of things later. Now, this is getting ahead of us also. You may have heard of a carotid massage or something like that, and it slows heart rate down. It's because of the vagus nerve that run in there. And that's the reason why. You start slowing that down and relaxing it, and it actually starts pumping blood to the brain. And sometimes people will pass out by that. And that's that carotid sinus when they massage that. A lot of times when they get people in a chokehold, it ain't because they cut the air off. It's because they cut that blood flow off at that carotid sinus to the brain, and they pass out. I went to a barber shop one time, and the guy passed out in a chair, and I asked the guy, I said, "Hey, were you shaving his neck?" He said, yeah. How'd you know? And I said, "Okay, well, that's what happened. He was massaging that carotid sinus, and the dude passed out." So that's kind of the way that carotid sinus part works. Now, this is into the upper extremity. Again, this is mostly arterial that you're seeing, but it talks about, these are some things, some landmarks later that you'll see. Now, you see where the radial artery and ulnar artery is. And chances are, sometimes, and you see especially where it's around the AC area, around the brachial area that it talks about, I have hit an artery before starting an IV. And you'll know it because it's under pressure, and it'll look like you just hung a bag of blood. It'll back up into that bag. And what do? Yeah, you stop it, pull it out, stop it with direct pressure, because it doesn't need to be that way. but it will backflow up into the bag sometime. And people that tell you they've never done it, well, good for them. But once you do that, then you will just heighten your awareness a little bit. You know, it's not going to kill anybody, but you just don't let it keep going. Also, someone that has high blood pressure real bad, and you nick an artery or something like that, they can bleed pretty good from it. You know, direct pressure, same way you control bleeding anywhere else. Even sometimes you get an artery started, I mean a vein started, an IV in a vein. If they have a real high blood pressure, I have seen it before to where, and this again, we'll talk about this more in vasculature therapy, but I have seen where someone with a real high blood pressure, even in a vein, that sometimes it would rupture because it's under so much pressure. It might not rupture as much if you don't use a tourniquet, but I have seen the pressure high enough, even in a vein, it backed the blood up into the IV bag. So that's stuff that we can talk about later. The let's see where we're at here. The thoracic aorta, we've seen a picture of it a little bit earlier, but it supplies blood inside the thorax itself, the lungs, the esophagus, and structures leading out to like even the rib wall, because you got to have your intercostal arteries are the ones that are around the ribs, and they're usually on the top of the rib. I'm sorry, on the bottom side of the rib. That's why when they do chest decompression or decompress the chest, they go over the top of the rib, because your major arteries for the ribs are on the bottom, and you nick those, you're gonna bleed pretty good. But your arteries, your aorta supplies the chest wall arteries, and it's a very vascular place. That's why chest wounds bleed a lot. But your arteries of your muscles in the chest wall that aid in breathing, it aids in stabilization. Visceral arteries supply. Remember, visceral means organ. Parietal means to the thoracic wall. Remember, we talked about in the lungs. You got your visceral pleura, which surround the lungs, and then you got your parietal pleura, which surround the chest wall. The anterior intercostal muscles or arteries, they form the subclavian system, and the posterior intercostal arteries arise directly from the aorta that go back. This thing here is going to drive me crazy. Good thing we're winding now. So Sarah, you just how are you doing tonight? Y'all been busy?
Yeah, we've been pretty crazy lately. It sucks because every night we have class and the nights I'm at work, so I'm trying to do both right now.
I understand. You can holler if you need something. You working with Ducky tonight?
Yes, sir. I'm working with her tonight.
Okay.
Hopefully it'll be easy.
I hear you. Okay. The thoracic aorta, as you can see a picture here, is you can see a lot that comes off of this and what it goes to. It is I'm not really worried about where they actually start, like T4, T5, but this is just kind of FYI. It gives you some kind of idea about where it's at inside your body. You can see where it branches off. It feeds the stomach, esophageal, right bronchial, mediastinal. As it gets down into the abdomen, it starts to feed the gut, the mesenteric area. Now, something we don't hear a lot about is as you see down to the bottom of the picture on the right, the superior mesenteric vein, superior mesenteric artery. We've heard of pulmonary embolus and things of that matter. You can actually have an embolus to the mesentery, which is the lining and the material that holds the intestines in place. And a lot of time that goes undiagnosed severe abdominal pain until it gets to the part they get an ischemic gut. But you can see all of this comes off the aorta to feed all of that, how vasculature is. You see how an abdominal injury, the bleeding can be, it can be either very sparse or it can be widely attributed to some area. Now, when it bleeds like that, when blood, remember this forever, when blood is not where it's supposed to be, it hurts. That's why when they have an abdominal, like a rigid abdomen or a firm abdomen, and it's painful, they it's because blood is leaking out somewhere. Someone laying flat, they might start having severe shoulder pain. This happens sometimes with ectopic pregnancies. It's because they're bleeding out in there, and that blood is irritating the diaphragm and the phrenic nerve attached to the shoulder, and it makes the shoulders hurt. So abdominal injury, blunt trauma to the abdomen, shoulder pain, or the abdomen gets rigid, it's because there's blood in there making it tense up. So even inside the head, when they have like a bad subarachnoid bleed that hurts real bad, it's because when blood's not where it's supposed to be, it hurts. It tells on itself. Over on the left-hand side, you see the hepatic artery that feeds the liver. Now, the liver is very vasculature. It's very dense. Sometimes they can get hit so hard that it actually just kind of breaks. It stays in the, hopefully it don't rupture the capsule, but it can bleed very, very quickly, and it can be pretty deadly. Someone that has a liver issue, a lot of times don't, it isn't real obvious, but it can be very deadly sometimes. When we get inside, oh my gosh, I can't believe this thing has quit working again. Anybody know anything why PowerPoint might do that to me a lot? I'm going to try to upgrade it tomorrow. It's embarrassing, really. All right, pelvis and lower extremity. These are when the aorta, the iliac arteries break off of the into there. I hear you, Don. When it breaks off from there, when it gets into the pelvis, like I mentioned last time, a pelvic fracture can be very detrimental because you look at the vasculature that goes in there, and not a lot you can do to it from the outside. And a pelvic fracture, that's why they, in some areas, they call it an alpha or trauma activation, because it needs to be surgically repaired. Sometimes automatically, it's at least a liter or two of blood into the abdomen like that. But you can see where that artery crosses on the outside of the pelvic girdle. That's why sometimes you can feel that femoral pulse. You have large or major bleeding down below the femoral pulse region. That's when you can do, that's where you would do like a direct pressure or a tourniquet over that upper part like that. So that's when it circulates down, and you can see when it goes into the femur, it goes into the inside, it goes to the top. Your femur is very vasculature. That's one reason we can start in some areas, which I believe is appropriate, they will start IOs in the lower femur because it gets into the system so quickly. And you see those large arteries that are feeding it. The system, venous circulation, of course, the head, the neck, the thorax, this is all when it's kind of showing, this is just the veins. This is where the blood is going back. Usually where you have a big artery, you're going to have a large vein. Now, the two major arteries that drain the neck and the head are called the external and internal jugulars. A lot of times you can see them when somebody screams or hollers, or like especially a kid, if they flex their neck, flex their chin down, you can see those jugulars. Now the jugulars are, remember, the carotids are arteries, the jugulars are veins. There's also, like we had the carotid sinuses going up, there's spaces between the membrane surrounding the brain that form venous sinuses. And that's where simply the blood kind of like, it allows it to pool a little bit. It's kind of a depressurizer when it comes out in order to transmit it to the right place. Now, the thorax, that's where the veins begin to drain from the anterior and posterior intercostal veins. It collects blood from there. And also the internal iliac veins drain the pelvis and the lower extremities. They drain it out and start bringing it back. So it's collecting a whole lot of waste products and bringing them out. The hepatic portal system is that's a specialized part of the vascular system that drains blood from the liver, the stomach, intestines, and the spleen. So it captures a lot of waste, a lot of used up bile, and transmit it to back into the system to be have the carbon dioxide removed and of course reoxygenated. So a lot of bad stuff comes out of there. So you can see whereas if it's not functioning properly, your blood can get bad, stagnant, set up sepsis in a heartbeat. So, and it pumps back up to get reoxygenated. And this goes on every second that you're alive. Now this here is veins. This is, if you look at the arm and the leg, this is where a lot of your IV sites are going to be. The cephalic vein, the medial cubita, the anafossa, which is the cubit, which is the AC. The forearm is mainly where I like to do, my IV sites at, but like I said, more on that later. Just kind of give you an idea of the veins access and stuff in your body. Now, most people have these large veins. It's finding them, or how good is their veins? What is the integrity of their veins? They could be old, or they could be obese, or sometimes people just don't have very good veins that are accessible. Some people's veins are on the surface, and some are buried very deep. Like you can't really see the veins in my AC or anything like that, but you can feel them. And I've thought about putting a tattoo over the outside of my arm because it feels like a pencil there. You just can't see it. Saying, "Hey, if I'm dying, stick me here." Now the composition of the blood is plasma mostly, which is made up of water. Plasma is the liquid portion of the blood, and it's very, very sticky. Back when I was flying, we would start. This is just FYI. If we had someone that needed blood replacement, severe trauma, the first thing we would give is tranexamic acid, which is TXA, it helps the blood to clot. Then we would do plasma because plasma has some clotting factors in it as well as is also volume expanding. So we would start that first, but it also has electrolytes, proteins, and glucose. If you spill it, like on the helicopter or on the ground, it is sticky. So if you've ever seen blood that spilled out on the ground or got on some equipment, it doesn't take long because it becomes real sticky. So 45% of cells are suspended in the plasma, and that's where your platelets are, your white blood cells, your red blood cells. That is floating around inside that plasma. Now, also in the plasma, you have, that's where your oxygen, your carbon dioxide, nitrogen, nutrients, that's where cellular waste and some other factors are picked up and transported around in there. So now you're going to hear this later on when you get into the IV therapy, fluids, electrolytes, and things of that matter. But the best thing to do for a problem is to put back the original as much as possible, whether it's car parts, human body, or anything. So the best replacement fluid in someone that has hemorrhagic shock or bled out, what's the best replacement fluid going to be? Everybody tell me what that is. It's blood. People will say, "Well, we don't carry blood." That's true. You don't carry blood on the ambulance usually. It's usually in the helicopters, and some critical care areas carry it. But whole blood is what they need. But if you don't have it, that's where the IV fluid comes in to build up pressure and volume, and hopefully sustain the blood pressure in circulation long enough to where they can get to definitive care, to where they can get blood and things like that. Blood carries, like you see here, the oxygen and nutrients. IV fluids does not. IV fluid just increases volume, perhaps helps circulate these products around a little bit, but it does not have any nutrient carrying or oxygen carrying capability. Now, red blood cells, those are the ones we've seen earlier in some of those pictures, kind of disc or donut shaped type cells. That's what they have, hemoglobin on it, and that's what carries the oxygen to the tissues. Now, some unique property about the blood cells is there's other things that bind to it quicker than oxygen, like carbon monoxide or a certain type of gases like cyanide that will bump the hemoglobin off of the red blood cells or the oxygen off of there and go. Sometimes they're bullies, they'll get on there and knock the oxygen off. One of the theories with COVID is that one reason that the oxygen levels, even with somebody with clear lungs after they've recovered from COVID, they'll have trouble oxygenating because they believe that the coronavirus acts kind of like carbon monoxide and steals a seat that the oxygen normally would have got. I went and visited my uncle today up in Meridian, and he's post-COVID now, but he's very, very, very sick. And even on high flow oxygen, when he's not talking, it's about 90. But when he started talking to me, it'd get down to about 70. So, what's happening with him is he's got a lot of inflammation. That's why the steroids are there. And even though the coronavirus is gone from his body, one theory is that the damage that was done to those cells by that coronavirus makes it unable to carry oxygen. So he was really struggling today, and he's got a long road to hoe. But I've seen people recover from it after being in these specialty centers, and I've seen people that was texting one morning and not with us anymore that night. That happened just recently to somebody that I know. So they think maybe that's what's happening with the red blood cells. The RBCs, red blood cells, they contain what we call an antigen on their surfaces, which something that might which it identifies it. It's kind of like a key code. And when you have an antigen, that is something that's an invader or a foreign, not really foreign, but it's something that needs to be watched. And that's why where you have an antigen, a lot of times you'll have an antibody. So that's where you get down into blood types. That's when you have like a antigen, you'll have a B antibody. So if you got A antigen and a B antibodies, if any other blood other than A, it's going to attack. Except for O. O doesn't have any antigen or antibodies. That's why anybody can take O blood. But if you're A, B, or AB, you got to be a little bit more selective with it, because if you have B blood, it's going to have a B antigen, which means it's going to have an A antibody. If you have B blood and somebody gives you A blood, it's going to clump together and it's going to fight because A antigen has a B antibody, vice versa. AB can only take AB blood because, or it can take A or B. It has A antibodies, but it balances out. So they're the universal recipient. O can only take O, but they can give their blood to anybody. When we were flying, we carried O blood on the helicopters. Why? Because we could not do type and cross match in the field like that. So we would give O positive to males. We would give O negative to females. And the reason that is that when let's say if you have a mother that has like O negative blood, that means that they don't have the RH factor on there. So if they have a baby that happens to be like O positive, when the baby's born, those antibodies will get with the O negative, that the negative part RH of it, and will actually cause a blood reaction, not in the first baby, but the second baby. There will be antibodies built up in the blood. That's why they have to have like a RhoGAM shot. So that's one reason why when we had a female patient, we would give O negative blood, and a male patient would get O positive blood. We didn't have type specific. That's why we used those, because anybody could receive that O blood. That's one reason we carry that. Now, in some places, they have a lot of blood drives that really request like O negative blood a lot. I got a sister-in-law who they're constantly questioning, bothering her, or asking her to come donate, because for the simple reason she has that O negative blood, anybody can get it. Now, if she ever needs blood and it's not available, she's in a bind. We understand how pulse and blood pressure works. Systolic, the contraction of the heart is the way you check the pulse over a bony area, something like that. Systemic vascular resistance, that's how dilated or constricted the vessels are. Now, if you've got, if the vessels are dilated, for example, like neurogenic shock, or someone has just had some nitroglycerin, blood pressure is going to go down, because there's not, you have to have some resistance to pump against for it to work. So the average adult, for the most part, has about 5 liters of blood. Now, what is an average adult now? I remember when I first started in this, they said 150 pounds, but now I think that's a very, very unaverage patient. I dare say is in the 200s now. So this was like an average patient, about 5 liters, as far as 150, maybe 175 pounds. Children have about 2 to 3 liters. This is average size, and infants have about 300 milliliters. How much is that? That's about how much is in a Coke, a can of Coke. So I think about that when I'm looking at a kid, and how much blood does it take for a kid to bleed out? So you figure what's in a Coke can is about how much that they got. Now, and it doesn't take long for that to happen at all. And I've got some interesting examples when we get into shock and trauma and things like that with it. So normal circulation in adults, perfusion is what we call the circulation. Organs have to be adequately perfused. In other words, getting enough oxygen to the cell, and it has to, just as important, it has to be able to take it out. So the perfusion is indicated what we call end organ perfusion. The perfusion that's taking place in the organs, that's when we know that there's adequate perfusion. That's why they say shock is inadequate tissue perfusion. Because when the organs start to die, and of course, then the system's going to die. Shock is the state of inadequate perfusion involving the entire body. The heart, and this is what you'll hear something later on when we get into trauma, but used to, back when I was an intermediate, or the old phase of what the advanced EMTs is, we used to, we'd have somebody with a low blood pressure or bleeding. They would want us, the protocol was, hey, give them as much fluid as they can. And what we would end up doing was the patients wouldn't stop bleeding. Now, if you think back about the plasma that has the platelets in it, the whole blood that has the platelets in it, and then I told you how IV fluids don't have any nutrient ability. They just provide volume and pressure, but they don't have any platelets. They don't have any red blood cells or anything like that. So what were we doing? We were filling them full of fluid that didn't carry oxygen, it didn't carry blood, and there's no way a clot would form because there wasn't any platelets in it. So these people were starting, eventually their blood would look like Kool-Aid because we diluted it so much. So we learned that, hey, now there's something called permissive hypotension. In other words, if you get a patient that is around 80 to 90, they want you to kind of keep it right there and not go any higher, because even a natural, you can blow out clots that way, and you're decreasing oxygen carrying capability. So the heart, naturally, what we were wondering about, hey, they're losing, we're losing pressure, and I think, man, we got to get that up. Well, the body itself was automatically lowering the pressure without us realizing what was going on at the time. So a lot of science and research went into play, and it says, hey, we might have been hurting people more than we were helping them. So the heart automatically lowers blood volume as a patient loses blood, and that means that it's simply maybe it makes those adjustments automatically to not have too much blood pressure in order to blow out clots and things like that. So the heart may, instead of pumping more blood that the clot or injury may not be able to handle, it may pump the same amount, yet at a higher rate. In other words, in pumping 100 cc's of blood at 70 times a minute with a lot of pressure, I may go down to 50 cc's of blood at 140 times. So, but what does that tell you? The blood pressure may still be holding, but yet when the heart rate's speeding up, it's having to work harder for some reason. So when the pulse increases, blood pressure falls because it's simply not filling back up with blood as much as that it should be. If it happens too quick, if you get a lot of blood loss immediately where the body can't adjust, that's when they start going into deep shock. Now, like I said, there are whole chapters on this later on, so don't get too much wrapped up into this now. But blood, when it's under pressure, it's kind of like if you hold your finger or thumb over the end of a water hose. Under that pressure, it's going to squirt harder. So at any one time, only about 30% of the blood volume is inside the heart itself. Heart, arteries, capillaries, the biggest part, it kind of gets through the heart pumps it through the arterial side pretty quick. It's when it goes to the capillaries, it gets into the veins and vessels, it kind of slows down a little bit. So most of the time, the biggest part of the blood volume is inside the veins and the venules, which is extended areas of the vein or smaller areas. This is what's kind of going on inside at the cellular level. You've got the cells of the body are the ones what you see on top, the little nucleus and look like eggs. But hydrostatic pressure is when fluid, it's already under some pressure always. Your vascular system should always have some pressure in it. So when this pressure flows into the capillaries, it's going to be a little bit under some pressure, and that's when the oxygen comes out, carbon dioxide goes in, and it does have a little bit of fluid transfer back and forth. But if it's under ideal circumstances, no shocks going on, the electrolytes is not out of place, it'll keep traveling on through without any stagnation. The lymphatic system, I remember once I had a nurse when my son was a baby. I said he had scratched his face and he had lymph running out. It's a straw-colored fluid, and a lot of times that's what makes a scab, or perhaps you've seen it if they get a rash or something like that. That straw-colored fluid that comes out, that's lymph. It's a thin plasma-like fluid. Sometimes it gets sticky, forms a crust around a sore or oozing lesion, and it circulates in vessels outside of the actual blood vessels, and it is a lot of time is a filter. It attracts foreign objects and moves them into the main circulatory system so it can be treated. But a lot of time these lymph glands can get occluded or not circulate for some reason, for poor circulation. And you've probably seen these patients with lymphedema, and sometimes their legs can get very, very, very huge. It may not be fat that they're dealing with, but that large force of lymphedema from it. The lymphatic vessels are pretty much on the, a lot of them are, some of them are deep, a lot of them are along the outside in the large areas of like the legs, the arms, and you can see, like I said, sometimes when it backs up and it can't get out right away. You've got lymph nodes that are supposed to act as filters throughout the course of these that lymphatic system, but sometimes they get swollen and infected and inflamed, or sometimes that's a source of a tumor to where it can have some abnormal cell growth and become cancer, like lymphoma and cancers of that nature. The brain is the body functions. If you look at it, the body functions as to carry the brain around. Now, this is just kind of a broad picture of the brain, not a whole lot there. It's just kind of showing you the main three portions of it. The cerebrum, which is the big part, the wrinkly part, the cerebellum, which is a part in the back. I'm not sure to describe how that looks, but it's the part in the right-hand side. It kind of looks like a small brain inside there. And of course, then you get the brain stem. The brain stem is primal functions that controls breathing, vital functions that keep you alive. But right in to the left of the brain stem, you'll see the pituitary and the pineal glands, and of course the cerebellum to the right is controlled for controls vegetative functions. I'm going to show you in just a minute. But that is the seat of consciousness, your personality. That's what makes everything tick right here. The cerebrum is the largest part of the brain. And as you can see, some of these areas here, it's been mapped out that controls bodily functions. Like the front part of your brain, the frontal lobe, has always been thought to be conscious thought, your personality. I took in a patient that had been shot in the front of the head one time. He had a through and through gunshot wound to the forehead, and the surgeon was, I guess we have our sick humor as well, but the surgeon's like, oh, he'll be fine. He's just not going to have a personality anymore. Nobody's ever going to want to date him again. But because that took out the personality part. Now you see in the part of the brain it says smell, and right below that, it's got two little finger-like things that stick out, and it is called the olfactory bulbs. They're large. They vibrate, and I gave an example the other day of when they talked to some boxers before, and some people that said that when they got a punch to the head, a lot of time before they got knocked out, or when they got knocked out, they had this strange smell sensation, and it was because probably those olfactory bulbs got jarred so much. You see the area about speech. So when areas of the brain, and if that part is damaged, you're going to have speech issues. Look at taste, hearing, your senses right around through there, language and reading. So those areas of the brain, when they become damaged, then that's when you're going to have some issues with those functions. The cerebellum, the part we saw in the back, that coordinates stuff like balance, the balance, coordination, things like being able to play instruments, be able to play a piano. It's actually called the little brain. It's like I told you earlier, it kind of looks like a big brain, but it's just a real small area. The brain stem, very primitive part of the body, very deep within the cranium. A lot of times it can't be accessed. My brother had a subarachnoid bleed on his brainstem a few years ago. Nobody would touch him. They said, "Hey, we hope it gets better on its own," and it did. Fortunately, that's been 5 years ago, and he lives a very active life now. Very fortunate. I rode with a paramedic that was transporting him from Picayune, and he said he could tell by the looks in her eyes when we read the paper that we was concerned. But after he got better, he said, "Well, how bad was it?" I said, "That's probably the worst place you can have one." So, but I didn't want to tell him at the time. The brainstem is divided up. You got the midbrain, the pons, and the medulla oblongata. We've heard that pronounced a lot of different ways, but that's what keeps you alive. Damage to the other areas, you can still survive, but a lot of time if the brainstem is damaged, that can be life-threatening, or you've heard people say, "Hey, they're brain dead." It might be that the rest of them that makes consciousness is damaged to the point that it's irreparable, but yet only the midbrain, pons, and the medulla are still going. That's just, the body will like maybe breathe or keep a heartbeat, but it won't be much used to it after that. So Uh, Inside the brainstem, there's an area called the reticular activating system, and that's what keeps you conscious, keeps you asleep. That is kind of a circulating, when I say circulating, that means blood, but that's something that keeps going, that has a lot of factors involved in it to keep you conscious, and then it even knows when you're sleeping, it's working as well. When head injuries occur, intracranial pressure, when things like that occur, then in those midbrain, and the area gets compressed, that's when you're going to start having like altered levels of consciousness, combativeness, interludes of consciousness. Hey, they were fine 1 minute, now they're combative, now they're okay a minute. So these areas are being affected. It also affects the way someone breathes with a head injury. They can have real fast, irregular breathing, Shane Stokes or Bias type respirations, which will be covered later. But that will that's all because that is affected. I'm going to show you a picture of this in a minute, but the meninges are thick layers that protect the brain. Now, you've heard of, and they're called the dura mater, the arachnoid, and the pia mater. Now, how do you remember which layers that they are? I used to look at it. Now, the dura is closest to the brain, arachnoid's in the middle, and the pia is on the outside. I used to look at it and say, well, I'll get a better picture here for you. I'm sorry, I said that backwards. The dura mater is on the outside, arachnoid in the middle, and the pia mater is close to the brain itself. So if you look from the outside going in, you can say the word DAP, or from the inside going out, I used to remember it as the word PAD, pia, arachnoid, dura. Here's a picture of like the skull and the way that it's, get my computer time to catch up with it. There we go. You can see where the skull runs right against the dura mater. In the middle, you've got the arachnoid, and the arachnoid, if you can see it, it actually looks like it's got hair underneath it. What that is a very vascular area. The reason it looks like a web of vessels. Arachnoid is kind of like spider. That's why they call it the arachnoid. It's got all these nerves and blood vessels in it, and that's why a bleed beneath the arachnoid space, subarachnoid bleed, is very, very painful. When you get blood in that area, very painful. And it has a large nerve area, and that's why they call it that, as you can see there, why that is. The pia mater, that's the one right up next to the brain. It has, it's an extremely thin layer. It directly lies on the brain. It kind of peels off like a layer of skin. That's how close it is to that. So all of those together make the meninges. When they get infected, meningitis. If you have a bleed between, as you can see, the arterioles, the red ones are deep down in underneath the arachnoid. Underneath the subdural area, you got the blue ones, which are veins. They bleed kind of slow, and you can't see it from this picture because it's not meant to show it at this time. But when you have like an epidural issue, it's on that between the brain and the skull. This is just another picture of the brain, the frontal lobe, to do with your judgment, your movement, kind of what makes your personality up. And the parietal lobe is sensations from the body surface area. And kind of knowing these areas kind of helps to determine where the injury will be. Now, everybody's just a little bit different. When they go to do like brain surgery or something like that, they'll actually map the brain. You may have seen this on TV. A lot of brain surgeries are done when the patient is they're have pain relief and stuff, but it's actually done sometimes while they're awake and when they're trying to map the brain out. And they'll have them to like count backwards from 10, and they'll start probing the brain, and they might be counting like I was watching one guy, he was counting backwards. He was going like 10, 9, 8, orange, blue, 7, and because they was tapping out to what how how his brain worked, and they would actually map it in order to do procedures. But I got to wonder sometime if, and sometimes they would touch certain areas. It would make their right hand move or their left hand move. It's kind of like that commercial they got to where it shows the guy and he's making the guy play a keyboard or something just as a joke. I don't remember which one it is now, but I remember seeing it. But that was fascinating, of course. Temporal lobe, as you see on the side, hearing, speech. The occipital lobe, the part that makes you see, is in the back of your head. So the optic nerve has to go through, you see that where it says lateral sulcus and down at the bottom. The optic nerve actually goes through there. That's one reason, if you have a lot of brain swelling, that optic nerve gets pinched in those two areas right there, and that's when they'll have like pupillary dilation or things of that matter. So, and we'll get into that when we get into head trauma. But it's showing you this kind of now, it kind of gives you an idea of what's going on with that. But the medulla down at the bottom, but it controls vital life as far as breathing, heart rate. The cerebellum, again, looks like a small brain down at the bottom of the limbic system. This is one that a lot of psychiatrists and things like that try to study, and when they give medications for it, this is usually the area that it affects. But the limbic system, called your emotional brain, deep-seated. A lot of times, if it's physically damaged, it's usually irreparable. But it's your emotions, motivation, mood, pain and pleasure. Sometimes if it is damaged, people will, like I've seen people with head injuries that constantly cry. Or there's a type of neurological thing that they, condition that's called PBA, and I can't remember the exact name of it, but sometimes people will have just loud, uncontrolled bouts of laughter from it. And that can be upsetting. And some people might think it sounds funny or whatever, but it can be upsetting to them. So I'll have to do this again here. Now, the central nervous system is the spinal cord that's an extension of the brain. It's the way the brain communicates with the rest of the body. It goes out through the foramen magnum at the bottom of the skull and down through the spine. Now, the central nervous system consists of the brain and the spinal cord, and it simply transports messages to the muscles and organs and transmits stuff back. So these, the way they transmit these messages are through what we call neurotransmitters, and it like dopamine, epinephrine, norepinephrine, serotonin, and the peripheral nervous system is that part of the nervous system that is outside of course the central nervous system. There are two portions: the somatic nervous system and the autonomic nervous system. Somatic nervous system is that is it's voluntary. You control that. It's when the nervous system transmits signals to like your arm and your hand, or if you're like sitting there texting or things like that. Things that you control is sensibly from the somatic nervous system. And then you look at the autonomic nervous system. This is ones for like a flight or fright, things you don't have to think about that happen. There's actually a reflex. I gave an example of if you were to touch a hot stove or something like that, before you even know it, a lot of times you've pulled back. Kids, little small children's is not developed that much, and it's why they were more likely to suffer a burn. Within the central nervous system, it divides even further. Let me back up one. The parasympathetic nervous system, you got the sympathetic, which is flight or fright. It makes your adrenaline kick in. It makes you kick into action. And you got the parasympathetic nervous system that calms the body back down. have a lot of times fainting from like the sight of blood or something that scares someone that alerts somebody. That is usually because the parasympathetic system kicked in. Like someone sees the sight of blood that may faint. They call that what they call a vasovagal syncope. What happens is when your body sees that blood, it automatically lets go of the adrenaline, and it's very quick to react. And then your parasympathetic system could kick in instantaneously, and your adrenaline set off the vasoconstriction, the rapid heart rate. In other words, for you to react. But when the parasympathetic system kicks in real quick, it stops that immediately. It causes the vessel to dilate, the heart to slow down, and that's why sometimes people faint at the sight of blood, because the parasympathetic system kicks in. You can make the parasympathetic system work voluntarily or therapeutically. For example, someone with a fast heart rate, they may tell them to bear down. The carotid massage that I talked about earlier is stimulating the parasympathetic nervous system. It's like using the brakes, if you will. The sympathetic system is the gas, the acceleration, whereas the parasympathetic system is the brakes. And sometimes when they start working against each other, which can happen for a short period of time, that's when the body's like, all right, I can't deal with it, I'm fainting, and it resets. But that's pretty interesting. Now, there are drugs that we can give that cause that, for like fast heart rates, very high blood pressure can induce like a vagal response in order to try to get that back down. So sensory nerves are messenger relayers. They bring information to the central nervous system. So if I touch something that feels hot or that feels cold, that means that those sensory nerves are telling my body, hey, here's what's going on. That's hot, we need to move it. Or that's sharp, I need to move it. And these sensory nerves are also not only touch, but it's basically your five senses, hence the name sensory nerves. It's important for like sight, taste, smell, balance, pressure, position. You got your proprioception. It's like, for example, your position. If you put your hand behind your head, you don't know where it's at. I mean, you can't see it, but you know where it's at. Something of that matters. It kind of works for that. Now, motor nerves, they carry impulses from the body or from the central nervous system to the muscle parts. It causes you to move that hand, or like, hey, that's sharp, I'm gonna pull away from it. And it's like, oh, that's, it gets the sensory bad smell, and it might be what the motor nerves are gonna make you pinch your nose or get away from it. So that's simply the way that those two systems work. This is the bottom of the nerves that come out off of the brain part, and it's called cranial nerves. And we're not going to have to memorize these, but I remember in the critical care school and stuff like that, we would have to. And like olfactory, optic, oculomotor, all of that stuff. But you see down at the bottom of the brain, and that's what these nerves affect. And it's called cranial nerves. A lot of them you can see in the face. Now, one that if you look at your terms, you can pretty much tell what they control, like olfactory, that's sense of smell, optic nerve, vision, oculomotor, that causes the eyeballs to move in the upper eyelids. You can also see where if these nerves were affected by stroke or pressure, why it would cause something not to work. Now, this next one that you're going to see on a test sometime, it's called the trigeminal nerve, and it's nerve number 5, I believe, or maybe I could be wrong. Let's see. Trigeminal nerve, and what that does, it supplies sensation to the scalp, forehead, face, lower jaw. It's responsible for chewing, and that's that trigeminal nerve. And it causes also, that's the nerve that gets paralyzed or when you have like Bell's palsy. So you have like Bell's palsy, it'll cause one side of the face to get numb or perhaps droop. But that's what's called a trigeminal nerve. Also, that nerve can become inflamed or pinched, and may have heard of trigeminal neuralgia, and it's like it hurts them real bad when they move their jaw or open their eyes or their mouth. Or you've heard of TMJ, trigeminal nerve neuralgia, TMJ, and that can also affect. It's because of that nerve right there that does that. So that one can become a real pain in the neck even. So some of the other nerves that goes on down, like the vestibular ocular, which pass through it controls the ears, hearing, and balance. And the vagus nerve is a big one you'll hear later on, and that is nerve number 10, and that's the one that controls it controls heart rate, it controls the parasympathetic system, and that's one that they work on, like to control fast heart rates and things like that. But the cranial nerve number 10 is the vagus nerve, and that controls some vital functions, and it can have and it can be stimulated by massaging the neck, the carotid arteries, or I could even I'm not telling you to do this, but if you were like on someone was on a heart monitor or stuff like that, and I have showed it in classes where I've had a heart monitor, but you can actually press on somebody's stomach, which puts pressure on that cranial nerve, and you can watch their heart rate drop. So it's kind of interesting how that works. Now, dermatomes are nerve pathways in the skin, different sections in the skin that like neurologists and neurosurgeons measure. Like T4, that is that's an area of the skin that responds to certain sinal nerves. That's usually around the nipple area, and it's simply how like neurologists and things like may map how far paralysis goes or what may be affected with certain areas of sensation problems. That's nothing that we're really going to have to pay any factors with. The eyeball, it's actually pretty tough as far as when considering. I know everybody's like, well, your eye's delicate. Well, the inside is, but the eyeball itself. I don't know if any of you have ever like took a lab or anything to where where you dissected maybe a cow eye or a sheep eye, and it's pretty fibrous. But the eyeball itself is it's a round, pretty round, not completely. But you got the conjunctiva. That's the white part that you see that covers you got a layer over it called the conjunctiva, and it covers your globe. And it actually under your eye and over the top of it around the edges. It actually doesn't stop there, but that's the part that actually still covers your inside of your eyelid. You heard of conjunctivitis or pink eye. That's when that becomes inflamed, and that or you get an allergic reaction to your eye, or it itches. It can hurt your eyeball itself, can itch as long as even under the eyelids. That's all the same membrane. Now, the behind the iris, which is the colored part of your eye, the circular part that you see behind that is where the lens is, and that is it actually gets harder and less pliable as someone gets older. That's why they got that presbyopia when people get around 40, to where they have to start wearing glasses for the most part, because that eye does not focus itself like it should, because it gets firmer. Otherwise, you got muscles on that your lens focuses, whether to distance or something further away. A lot of times it'll focus itself easier because it is a lot more pliable with those muscles when they're younger. When they get older, it loses its pliability, and you can only pull so hard on it. That's why glasses have to take over with it. But the lens is what focuses. It gathers an image, focuses it on the retina, and it usually focuses upside down on the back of the retina, but your optic nerve and your brain fixes it and turns it right upside for you. The retina is in the back of the eye, very delicate. They say it has a consistency of about like warm butter, easily torn, and even sometimes when it is torn, they're not able to touch it to put it back in place, but they may actually position someone and hopefully it falls back in place the right way. Now, they're getting more and more advanced with lasers and stuff, so that might not be such a bad deal now as it used to be. But it's on the back of the retina, there's millions of nerve endings, and what they do is they respond to light by transmitting nerve impulses to the brain itself, the optic nerve to the brain. Now, humans have those cells that are in the retina. You have cones and you have rods. Cones are responsible for transmitting color, and rods are for shapes and dimensions. And the way I used to remember those is like cone, CO, color, and rods would be the other one. So, and cones require extra light to work. That's why the darker it gets, you pretty much lose your color, and you're able to distinguish shapes and stuff a lot longer than you are color. They are very sensitive to light, and it's like if you hit them with a bright light, they're going to get stunned and quit working for a while. That's why when you see a light or look at the sun real quick, you're not able to see for a while because it actually stuns them, and they're like, "Oh crap, I got to rest for a minute." So central vision, what you see straight ahead from you goes right back to called the optic nerve, where that's open at in the back of your eye, the macular area, and your peripheral vision is kind of at an angle. The inside of your eye is hollow and it's picking up things that angle your peripheral vision. The skin is considered the largest system of your body. And what's it for? It's insulation. It protects you from the outside world. It maintains homeostasis. It's complex. It's got many organs and organelles that are inside of it. And over time and over age, it breaks down. It doesn't work as much, but it keeps stuff in as well as keeping stuff out. It is divided into two parts. You've got your epidermis, which is on the outside, which is not very thick. In fact, when you have a bad sunburn, your epidermis peels off. Not a lot of nerves and stuff in the epidermis. That's why it doesn't hurt that bad. But once you get into the dermis, which is very, very not far away, that's when your nerves start. That's when a sunburn peels too much, or they call it get it into the quick. That's when it starts to hurt because it gets into those areas. It may even start to bleed. But the epidermis, you got cells that start at the bottom. They constantly divide. It's constantly dividing off, sloughing off, but it's constantly having dead cells made. They die quick and they flake off, and it's constantly made again. But that is the first line of defense of the human body. Now, sometimes it's thicker in other areas, like the soles of the feet, the back, the scalp. It's pretty thick. In some areas of the body, it's only 2 or 3 cell layers thick, though, in some areas. But the outermost area of the epidermis is rubbed away and replaced by new cells. It's called like the germinal layer, and that's constantly going on. Some places more than others, like on the soles of your feet, bad shoes, it's going to get into the quick pretty quicker. Below the epidermis, of course, is the dermis. It's tough, pretty elastic, made of connective tissues, a lot of collagen fibers, elastic fibers. You're going to have in there little blood vessels, hair glands. It's going to, your sweat glands are going to be in there, oil glands, hair follicles, and that's where your nerves is that hurt. Your sweat glands are, of course, making sweat to produce, to cool you off. Those glands can become clogged up sometimes and get dirty, and that's when like you'll have like the zits to form, zits or blackheads, things like that. That's where these pores and open areas get dirty and full of junk that they can't get out. Below the dermis, you got what they call the subcutaneous layer, and it's a lot of adipose tissue or fat in that area. Sometimes when you have someone with a deep cut, you look down in there and it looks like if you've seen catfish eggs or something like that, that is fat tissue. That's what it looks like. I used to describe it as it looks like a bunch of catfish eggs, but it's yellow. Those cells are usually round and sometimes it looks like a bunch of little yellow BBs or something. But when you see that yellow discoloration, sometimes it's white in some areas, that is a subcutaneous or fat tissue. It's thick, fibrous. A lot of times it goes down into what the next layer is the fascia, the subcutaneous muscle. Areas, for example, like orifices, your mouth, nose, sexual organs, lower GI tract. Those are lined with mucous membranes. It's skin, but it's got a protective layer that protects bacterial invasion, and it does secrete mucus to try to keep things flushed away. But then also, sometimes it's easier for things to cross over those barriers and to get in your system. Like if blood or something gets splashed on mucous membranes, there's a chance that it could be quicker absorbed into the body than it would if it'd be on your arm or other intact skin somewhere else. But your skin, you know, it's to protect you from the environment. It's like it works like a big radiator. It receives information like where your sensory nerves are, your motor nerves. It's how it reacts to it. But the big thing is it helps with the heat and the warmth of your body. It's simply the blood vessels constrict when the body is in a cold environment. And when you get hot, your blood vessels want to dilate to where it can bring the blood to the outside so the heat can evaporate and try to cool you off. The digestive tract, it starts actually at the mouth and goes all the way to the rectum and everything in between. Your mouth, salivary glands, is all considered part of the digestive tract. So gallbladder, pancreas, they might not handle the food itself or the liver, but they secrete the enzymes, the chemicals, the bile that's required to complete digestion, which is simply digestion is a process of food is metabolized and used to nourish the body. Now, the abdomen is actually starts at where the diaphragm is. The thoracic cavity is above the diaphragm, but the abdominal cavity is that below the diaphragm, all the way down into the bottom of the pelvis in the pubic area. It's divided up into different areas. I'll show you in just a minute. But down in the pelvis, at the very bottom, it kind of divides into like a subpelvic floor area where the bladder and things of that nature is. But it usually contains all the organs. It contains a lot of nerves divided up into quadrants. The abdominal quadrants, I put this picture in here because you can actually see where the organs are a little bit better. But in the upper right quadrant, you know, your liver, your bile duct, your kidneys, your colon is in every one, and your small intestine and large intestine is in every quadrant. But it is very important that you sit down and study and know what organs are in these areas. Now, right lower quadrant, you know, what's in there that could kill you? Of course, the vessel, the guts or vasculature, you do have the iliac artery that may be in there. But if you look up into the upper right and left quadrant, in the right quadrant, you got the upper right quadrant, you got the liver that can bleed out very bad. The left upper quadrant, you got the spleen, which can bleed out very bad. Someone comes to you and says, "Hey, I'm hurting real bad. My right upper quadrant, I've been nauseated and throwing up." You know, you figure you got your gallbladder up there, some other, and a few other organs, but kidney stone toward the back. You got kidneys on both sides. You see how high up they are. Ulcers could be anywhere in the duodenum area, left upper quadrant area, and the abdomen. These nerves sometimes you can't really tell sometimes where the abdomen's actually hurting. I've had people having appendicitis. Appendices you see down in that lower right quadrant down there have pain from the navel all the way across because that sometimes it diffuse pain. They can't really pinpoint where it is. That's why abdominal pain sometimes is vague, and they have to do CT exams or MRI to be able to tell what's going on with it. So abdominal pain can be very tricky. It can be something very minor, or it can be something very serious. That's why it's always good to get that checked out. This just again the stomach, the pancreas, the duodenum. It links the stomach to the small intestine. Your ureters, which is they transport the urine and liquid waste out of the kidney down to the bladder, and that's most of the time where kidney stones actually get trapped. They get trapped in there. They got smooth muscle inside the ureter, and it's constantly trying to push and contract. That's a lot of times where that kidney stone is located. All right, the mouth, oral cavity. I think we pretty much know what that is, but tongues, lips, salivary glands. Salivary glands actually start releasing enzymes that helps food start to break down. The oral pharynx is that's actually the part of the mouth that goes to the esophagus and the trachea. It's two words together. Oral meaning mouth, and pharynx means that's behind the mouth that goes to the top of the trachea, and the esophagus is the tube that takes the organ that takes the food from your mouth to your stomach. Now, it's behind the trachea, and sometimes people can, and it also goes along the vagus nerve, but it's directly behind the heart and the trachea, which means that many times esophageal spasms, you look at your anatomy, can make someone think that they're having a heart attack. But you can't blow chest pain off, so it might be your esophagus. You always got to check out the heart just to make sure that's not what it is, but it can mimic it a lot of times. And esophageal spasms can be bad. Not kill you, but they can hurt so bad. Because like if you ever swallowed a big gulp of air or something like that, and it can hurt because your esophagus starts to spasm so bad. But your stomach, it gathers the food and it breaks it down. It starts to break it down. That's where it kind of breaks it down into small pieces, and it moves it out into the small bowel. It starts to break it down. But the muscular contractions called peristalsis pushes it out of the stomach into the intestines. And when it's broken down, a liquid form like that, they call it chyme. While it's in the stomach, if it comes out of the stomach, you call it vomit. It's just that simple. But as long as where it's supposed to be, it works out all right, I guess. But the pancreas, it's a lot of fat. It is a solid organ, and it's behind the stomach, behind the peritoneum, and it's in an area to where it's usually straight back from the xiphoid process in that area. Pancreatitis can be very painful, and what causes pancreatitis is your pancreas gets inflamed, and it starts secreting a lot of these digestive enzymes. And if you remember on the pH scale how we showed where stomach acid was down like a 1 or a 2, these pancreatic enzymes are that type of acid, and it actually starts eating on its own self. That's why it hurts so bad. That's one reason they says, well, we can't have any digestive juices stimulated. And one of the treatments for pancreatitis is they don't let you eat. They put you on like IV therapy, and they starve you so your body will not make those digestive juices to eat away at itself. Sometimes it can get so bad that it eats into its own vessels and stuff and cause bleeding. Certain parts of the pancreas, like cancer or things like that may form in it. Pancreatic cancer doesn't have a real good prognosis. Some people do better than the others, but it depends on where it's at exactly. Now, the pancreas is an endocrine gland, and it has what they call the islets of Langerhans on there, and that is the part of the pancreas that produces insulin. So if those are damaged, insulin's not going to be performed, one becomes a diabetic. So that's how that's measured. And now the liver metabolizes just about everything that you put in it. It works hard. It's in the right upper quadrant mainly, but it goes across to the left upper quadrant. It metabolizes medicines, poisonous substances that are put in there up to an extent. It makes things for like blood clotting, production of normal plasma are formed here. It stores sugar or starch for immediate use. When the body breaks down, like all the glucose, it'll start releasing glucagon and as a form of energy. But once it depletes, then the body's out of energy. Now, even though the liver metabolizes a lot of stuff, it can be overwhelmed. Some things are very bad for it. You know, a lot of alcohol over a lot of period of time, your liver finally just says, "The heck with it, I can't deal with it anymore." Acetaminophen or Tylenol, those overdoses, Tylenol can be very toxic to the liver. It's okay if you take it in recommended dosages, but very strict guidelines in it. I don't think they put enough warning on it. But an overdose of Tylenol won't bother you today or tomorrow, but starting in 4 or 5 days, your liver will start shutting down. And a lot of times it's irreversible. It has to be a liver transplant or something afterwards. I transported a 6-year-old once that had gotten into a bunch of Tylenol, and her liver enzymes was doubling every 12 hours. And I think she ended up dying. couple weeks later. But they're just not. The only way to do it is get a new liver. Forms of, I've heard people like getting lead poisoning, making like certain types of moonshine stills, or bad cases of meth went around in this area for a while, and it was causing people to go into liver failure. Now, liver failure, the liver is supposed to remove ammonia out of the blood. Sometimes people with altered levels of consciousness, I've seen it was because they were in liver failure, and sometimes they get very combative or just totally out of it, feel like they're on drugs and stuff, and it turned out that they were like in early liver failure. Sometimes you may have repetitive patients that you have that is known to have cirrhosis or ascites or things like that, and sometimes you'll pick them up and they'll be normal, and sometimes the family will call and say, hey, he's out of his head again. It's because the ammonia levels get so high because your liver can't process it. But your liver will take a lot, but it'll finally get to where it just wears out. It'll get like cirrhosis to where it'll just get hard. It's unable to process anything. Sometimes what goes on over a period of time is you can get cirrhosis without drinking a drop through like a fatty liver, like excess sugar and processed foods build up for so long, and fat cells will overtake the liver. And after a period of time, if that's unrecognized or untreated, it'll turn into cirrhosis and cause liver failure. My cousin probably drunk 3 beers in his whole life. He had a liver transplant about 4 years ago, and they said it's because of undiagnosed fatty liver. So the liver will take a lot, but it's like everything else, it can wear out. The small intestine it's a long part of the intestine, sometimes about 20 to 30 feet, depending on different people. But it's where a lot of the digestion is absorbed and put into the lungs. Got 3 sections: the duodenum, the jejunum, and the ileum. And it also produces mucus. It produces enzymes. It breaks down foods and nutrition a lot more than what the stomach does. And that's where most of the nutrients are absorbed, like your vitamins and things of that matter. The large intestine, sometimes 15, 20 feet, depending on the individual. But it mostly is where it absorbs water and fats. Now, it's usually where all your water absorption takes care of. But sometimes, if your your large intestine is diseased or sick, or for some reason coated and not absorbing water, that's when people get diarrhea or things like that. Or if people are not drinking enough, they'll get constipated because sometimes the large intestine will absorb all the water it can out of the stool, and it's kind of like you've got concrete in there, and it takes help getting it out. So that's kind of like what happens there. The appendix, it can become obstructed and inflamed. It's actually a hollow appendage off of where the cecum starts coming out of the large intestine. It can get inflamed and it can be taken out, and usually people doesn't even miss it. I've heard different stories on why it's actually even there. And of course, you got the rectum. It's the lowest end of the colon. It's what connects the sigmoid colon to the anus, and it's where like feces and stuff like that is stored until it's ready to be expelled. A lot of time it's prone to develop cancers, and but it is very muscular, and sometimes when it is stimulated, sometimes it can expel waste contents pretty quickly and things like that. But also, it's where if it is constantly under a lot of pressure, the vessels are trying to pump against pressure, and that's when like hemorrhoids and veins like that will develop as well. So the physiology of the gastric system is salivary glands produce enzymes. It starts breaking food down. Of course, your stomach, liver, and pancreas, and it takes these sugars and fats and makes it into amino acids, which is nourishment, which is building blocks for the body. once it gets through with the digestive system, the liver can completely process it and transport them into the bloodstream to the heart, and the heart pumps it out to the cells to where it can actually be used. The endocrine system is exocrine glands, which means these are with ducts. It usually has like plumbing that transport these variants of substance through the rest of the body. Say like sweat glands, get sweat out. That's why they tend to, in certain areas, you have to wear deodorant and things of that nature. The endocrine system is chemicals that are used inside the body. As for example, hormones, chemicals that react upon certain organs, releases testosterone, estrogen, and it acts upon target organs in order for them to be able to provide their function. The hormones are agonists. That means they make things happen. For example, testosterone gets into the body, it will react on testes to perform sperm or secondary male characteristics. It also can, for example, the pituitary can release the luteinizing hormone or oxytocin that will react upon like breast tissue to form milk. So it reacts on target tissues. The pituitary gland is the master gland of the body. It controls it is the control over all the endocrine glands. Underneath that, you have the hypothalamus, which controls like heat, cold. For example, like some people with head injuries that get the hypothalamus damaged, they'll actually have like problems with keeping their body. They'll either be too hot or too cold. I've seen them where they constantly sweat and had to have cold towels and fans blowing them a lot. So that can be detrimental if it's that type of a deep brain injury. So the thyroid gland is at the base of the neck. Sometimes you can feel it right around your laryngeal area. It secretes like iodine, thyroid hormone. It can get, thyroid has to do with a lot of where your metabolism gets, but you can have actually a thyroid storm, which you get into in the medical part, that gets so bad that people can actually have high blood pressure, go into seizures, have very bad temperature regulation issues. Went over that. The adrenal glands is that's where your adrenaline is created in the body. It's right on top of the kidneys. They can get damaged over time. It can be people that have issues with that have adrenal insufficiency may get like Addison's disease. Their metabolism slows down to the point to where they'll get like a big moon face. Their face will swell up. If you look at pictures of like John F. Kennedy, he has kind of a round face. He had Addison's disease. We had an adrenal gland insufficiency. Some people will have this also to where it's called like Marfan syndrome. They'll get like tall and extremities appear to be long, like Abraham Lincoln. He had that disease. The reproductive glands and hormones of the body, we're familiar with that. Testosterone is a major androgen manufactured by the testes, and women actually make about 3 of these: estrogen, progesterone, and human chorionic gonadotropin. As people age and get older, these hormones are diminished and sometimes have to have artificial placement. Progesterone, it's what prepares the uterus for implantation, causes menstrual cycle regulation, and you got the pineal gland that is also has to do with it quits working as you get older because it produces like melatonin and serotonin in the brain to help you with your circadian rhythm, to help you sleep, helps certain types of moods, and as we get older, that stops working as much. That's when people start buying the melatonin over the counter. The Urinary system maintains fluid balance in the body, primarily with use of the kidneys, and of course eliminates waste through specific genitalia that is assigned to the sexes. If you look at this one here, you can see how kidney stones may form and may work, but the kidneys pull the toxic waste, the liquid portion out of the blood, filter it out. They may reabsorb water or sodium if it needs to be, depending on what hormone is sent from the brain. And it's kind of like the urine actually falls by gravity down the ureter into the bladder. Now, if a kidney stone forms, it gets trapped in that ureter somewhere. A lot of times they'll pass out. However, they can be too big to where they got to bust up with lithotripsy, and they spread out, but it needs to come on out. And as you can see where this is the male, of course, you see the prostate gland. It can become inflamed and compress that urethra narrowing and make it hard for the urinate. Also, you got below that, you got some other glands, the Cowper's glands on the base of the penis, things like that can become enlarged and cause urine to also be difficult to pass. For the most part, for the male organs lie outside the body. A lot of the female organs are contained inside the body. Here's a picture of the male, of course. And if you look on the right, I want to show you how just the anatomy, how you can see where there's some structures could be bleed that could cause what could cause bleeding to come out of the bladder. You could have like the prostate issues. You see where the seminal vessel goes all the way, wraps around into the back of the bladder. They can have infections or epididymitis in there in those areas that could cause pain, irritation in any of those areas like that, can even cause difficulty to step down. On the left, you see where the testes are on top of that's the epididymis. Those can become very inflamed, painful, especially in younger persons, and infection can travel up the gland into the bladder and cause a lot of pain up there that they're really not able to pinpoint either. Females, as you can see, on the right to where the fallopian tubes and the ovaries are just kind of floating there. Certain types of trauma that can be damaged or impinged upon. That's where like an ectopic pregnancy will form in the fallopian tube instead of the pregnancy forming inside the uterus. You see how thin that is, how it can rupture, but it's very vasculature. Okay. The cells of the body, like I said, when we first started out, that is kind of, it's not real exciting. It's kind of complex. It's like, man, what will I need to know that for? But cell death spreads to organ death, spreads to system death, and it's just kind of a hierarchy that can eventually kill a whole system. So just to break that down, we're past that part, the chemical part. So this is the end of the anatomy. I'm not going to get into the physiology part tonight because that is kind of, this is part of draining, but we'll try to catch up on our next meeting. So right now, the pin number that I'm going to assign tonight at this point is, let's see, 118-830. 118-830. So any comments, questions, or concerns about anatomy? In every section, we're going to refer to some anatomy depending on what we're working on. So, well, I appreciate your patience of getting through this part. This is not one of the easiest ones to teach. You can't really make it that exciting. It's just a kind of a necessary evil, but it is very important. Okay, the next class is going to be Wednesday night. And the way this works is that I work 7 days on, 7 days off. And, for now, the only way we can make this work is like this week, it was Thursday, Saturday, Monday, Wednesday. So I'll be back Wednesday night, 6 o'clock, and I'll also record these. It's available on the web. And after Wednesday night, we will not meet again until the following Thursday. Let me pull that up. I'm going to try to get this schedule posted. There's a couple of changes, but the next night we will be together is 20. We'll be back here on the 20th, and after that, it won't be until the 28th. Thursday night, the 28th. So Robert had posted, he had sent out a schedule. I want to make sure everybody gets this. I'll just tell him again tonight. The module test, we should work on it tonight, but there again, I'm not going to say a whole lot because we still hadn't put the physiology part into it. We're running behind on that. If you want to look ahead, that's fine. But the module test, if we have to slide on it one night, that's fine. It was supposed to be due tonight. However, I've got the flexibility to make a couple of these changes because of there was just no way we could get anatomy into the one night lecture like the book thought we could do. I will send Rob Roy an email after we get off of this to make sure everybody has the schedule and the times and everything. Now I went on the calendar last night, I think on the other site and posted it on there when the next meetings and stuff's going to be, and try to get the subject matter in there. I'll go back and make sure that that's on there. But anybody can. I'm going to give y'all and Donna, don't worry about that. We're real flexible about that. We know people are just coming on board and stuff like that. So the main thing is we get the information you need, that what you can use, and if you've got Robert Roy's email address and things like that, things that you don't have, send him an email, tell him what you don't have, so he can get that taken care of for you. He's having to help out on the EMT class tonight. That's why he's not on here with us. But please send him an email on that. Now, my email address, I don't mind giving it out if anybody wants to write this down, but it is lowercase blmjr_EMTP@att.net. So it's blmjr_EMTP@att.net. Please feel free to email me. And like I said, I want everybody here to be successful. So don't worry about it. If you don't have all your information or all your resources yet, don't freak out about it. We'll get it to you. That's the whole idea of having these type classes, because everybody's working, everybody's busy, and we're all here for the same thing. So send me an email if you need anything else or think anything else between now and then. But I'll see y'all Wednesday night at 6 o'clock. Everybody have a good night. That's it, Donna. That's it. All right. Good night, y'all.